It's 9 o'clock. It's time to start. I welcome you, everyone, to this dissertation. Today, Maria Svenvik is going to defend her thesis, Prediction of Spontaneous Preterm Birth, Clinical and Immunological Aspects. A special welcome to you, Maria. I'm glad you could make it.
Thank you.
And I'm also very happy to introduce a faculty opponent, Teresa Cobo, who is at the Fetal Medicine Research Center and the Hospital Clinic, University of Barcelona, and an accredited researcher and senior consultant. And you have written very impressive papers in the field of fetal maternal medicine, especially biomarkers in preterm birth. We're very happy that you could take on this task.
God morgon.
God morgon, yeah. I am Jan Ernerudh. I'm the host today, so I will introduce everyone who is involved. And I've now come to the examination committee. There are 3 persons in the examination committee. It's Bo Jakobsson, professor of obstetrics and gynecology at Gothenburg University and Sahlgrenska University Hospital, who is an authority in the field of preterm birth. Welcome.
Thank you.
And we have Jorma Hinkula, professor of molecular virology at Linköping University, who is a member of the committee. Welcome. And we have also Eva Swan, professor of cardiology, who is from Linköping University and also the chairperson of the committee. The supervisors to Maria have been myself and Maria Genmalm and Marie Blomberg. So you can imagine we have one Maria, another Maria, one Marie, and then myself. It has been tough. I will also now explain the procedure today. So first, Maria will tell us about some errata in the thesis. Then Teresa will give a general introduction to the field. Maria will then present the main findings of the thesis. After that, we will have the main event of today, the discussion between Maria and Teresa. Thereafter, the examination committee will ask questions. Anyone is free to ask questions also, which can be done actually during the thesis or when the examination committee present their questions. And you can do that by using the chat function in YouTube. After we are ready with all the questions and discussions, the session will be closed, and then the examination board, opponent, and the supervisors will meet separately and discuss the outcome of the thesis. During this period, there will be a Zoom link presented on YouTube, so anyone who likes can chat with Maria and each other. Then we will come back and announce the results. Okay, so I think that is it. And now I give the word to Eva Swan, please.
Thank you so much, Jan. And now, Maria, we will start the session and you will show your errata list, please.
Yes, thank you. I have left out some minor writing mistakes and grammatical errors, but the full errata list can be found on digitally on Diva. But for now, I would like to present these errata. And on page 18, on paragraph 1, line 2, the sentence, "No studies on PAMG1 fulfill the inclusion criteria," should be added. On page 50, paragraph 2, line 1, for study 2.4 should read for study 2 and 4. And also on page 50 in the second paragraph on line 8, the sentence, "Since there are no previous reports on levels of oxylipins in preterm labor, no sample size calculation was performed," should be added. On page 72, paragraph 3, line 3, FLT3 binds to should read FLT3 ligand binds to. And on page 78, paragraph 4, line 4, 1.5% should read 1.3%. And then on page 110, the oxylipin 5,6-epoxy-eicosapentaenoic acid should be added to the appendix. In the papers, in paper 1, on page 3, medical journals should, of course, read medical records. In paper 2, on page 6, paragraph 1, in the beginning of line 14, the number 16 should be removed. In paper 4, on page 4, paragraph 3, line 11, the biobank was approved, should read the study was approved. And also in paper 4, on page 9, paragraph 2, line 4, again, FLT3 binds to should read FLT3 ligand binds to. And finally, in paper 4, on page 10, in paragraph 2, line 2, 107 divided by 7,095 equals 1.5% should read 107 divided by 8,027 equals 1.3%. Thank you.
Thank you so much. And now we leave the floor to the opponent, Teresa Cobo. Please, the scene is yours.
Good morning, everyone. Thank you to come today to the dissertation of Maria. I'm sure that we will enjoy a lot with her work because it has been really nice to read all her work. It's really easy to follow. But today we are here because we are going to talk about an important problem. We are going to try to predict a relevant problem in maternal medicine. The prediction of spontaneous preterm birth. And we are going to talk about clinical and also immunological aspects. First, I would like to thank Jan Ernerudh for contact with me and give me the chance to be the opponent today. I'm really happy for that, and I'm very happy to be part of this Swedish thesis, because with Sweden I have a nice connection. And long time ago, maybe 7 years ago, I had the chance to be there with Bo Jakobsson and also with Marian Kacelowski. He's a researcher from Czech Republic, and we got a strong network. And because of that, I have all these papers that you mentioned, Jan, about all these papers related to infection and inflammation. It was also because of the collaboration with Bo that gave me the chance to be part of his team, and I really learned a lot with him. But
excuse me, Teresa. Excuse me. Can you hear me?
Yes.
Yeah. You could maybe put in the earplug, because the microphone is. We can hear you better now, I think.
Now, okay, because I lost one of them, but now it's. Did you hear me? What I?
Yes. Yeah, we heard.
Yes,
we
okay.
heard you. Yeah.
Yeah, but now it's much better. Now it's much better. Yeah. Thank you. Okay,
Thank
but
you.
Today we are going to talk about this problem about spontaneous preterm birth, and it's important because our clinical prediction of preterm birth is really poor. So we used to base our diagnosis on uterine contractions when a woman is contracting and comes to the emergency, and also we observe the CTG and we observe that there are uterine contractions, and then we assume that this woman is going to deliver. But majority of times we are wrong. So only 1 out of 10 women with a diagnosis of preterm labor that we are thinking that she's going to deliver will finally deliver before 7 days. And as you can see here, majority of women with a diagnosis of preterm labor will finally deliver at term. So it is very important to target who is the really high-risk group, because it's the high-risk group, the woman, who really benefit from our antenatal management. There are few strategies that have shown to improve our neonatal outcome. One of them is, of course, to transfer to those centers who have an EQ unit. Also, the antenatal steroids and the magnesium sulfate. But nowadays, we are treating at a similar way to all women who come to our hospital because they are contracting. We are treating all of them with these steroids, with this magnesium, with this tocolysis. And as you can see here, there is only 10% who really benefits of our action, because majority of them are unnecessarily overtreated. And this has a cost. It has a social cost, because these women have anxiety, and maybe they need a medical leave as well. Of course, there is a medical cost, because we cannot forget that these treatments have side effects. And also, of course, it has an economical cost for hospital, because they are unnecessary hospitalized. And we cannot forget that, of course, all the treatment has also pros and cons. And a nice example is with antenatal steroids. The antenatal steroids have shown that are really benefit for the baby, but if the baby is going to the liver preterm, if the baby is going to the liver before 34 weeks, the antenatal steroids have shown to decrease the rate of respiratory distress syndrome, intraventricular hemorrhage, necrosizing enterocolitis, the neonatal and the perinatal mortality. However, if we treat with antenatal steroids a woman who finally is going to the liver near term, these steroids maybe can have a negative effect, because it has observed that these babies who finally are born nearly term or at term have lower birth weights, also have observed a higher rate of hypoglycemia, a poorer scholar performance, vulnerability to stress psychiatric disorders. And also in the adolescents, it has been observed a higher blood pressure and also an insulin resistance. So we need to treat if it's necessary, but we need to take into account that if it's not necessary, all our actions have a negative effect. This is why it's so important to know the mechanisms involved on the origin of spontaneous preterm birth. And as Maria will explain us, there are two mechanisms that are really important. One is the infection, and also this tolerance between the mother and the fetus, the immunological aspect. Me, with Boo, with Marianne, with all other researchers in the world have been studying for years the origin of spontaneous preterm birth in relation to the infection and inflammation, and also Professor Romero, of course. And we have observed that there are 4 phenotypes of women with preterm labor. There are women who doesn't have infection and there is no any sign of inflammation. There are women where we can only observe elevated concentrations of interleukins. There is an sterile inflammation, but there are no evidence of infection. There are women where we only see a positive culture in the amniotic fluid, however, with a low level of interleukins. And the last and the worst group is the group of women with infection and also with inflammation. And what is the clinical relevance of that? The clinical relevance is that this group with either inflammation or infection are a group of high risk to deliver in 7 days, because there is a group with an early onset of symptoms, an early gestational age at delivery, and a short latency to delivery. If we move to our data in Barcelona, you know that we are performing an amniocentesis in women with preterm labor below 32 weeks for this indication, just to try to identify or rule out the infection and inflammation. And this is part of our clinical approach. As you can see here, there is 17% of women who decline the procedure, but majority of them accept to do an amniocentesis for this indication. when there is a woman with preterm labor who comes to our hospital and we decide to admit her, we start with steroids, we start with tocolysis, and if we suspect that the delivery is imminent, then we also start with magnesium sulfate. In the amniocentesis, we look for glucose, we look for the gram stain. Also, we perform a culture in the amniotic fluid, and we also check for interleukin-6. And what we have observed is that in this subgroup of women with preterm labor below 32 weeks, majority of them, 60%, there is no sign of infection and there is no sign of inflammation. But most important from a clinical point of view is that the latency from the admission to delivery is 50 days. You see here the median and the 25 and 75 percentile. Look here. There is 40% of women with inflammation or with infection. And let's see here what happens. The latency to delivery is very short, around 2-4 days. So who is going to deliver in 7 days? This group with infection and inflammation. This is why it's so important to try to look for this group, because this is the group who is going to benefit from our antenatal management. This group maybe doesn't benefit from this antenatal steroid that we have mentioned before. And to look for that, we need to look for the innate and the adaptive immune system. And this is what Maria is going to explain now. What are the biomarkers that are related with this innate and adaptive immune system? And there are different ways to try to look for infection and inflammation. The better is to perform an amniocentesis because it's the closer to the fetus, but this is an invasive procedure. Maria is going to talk us about the maternal plat as a biological compartment to try to mimic what happens in the amniotic fluid. So the objective of this thesis that Maria is going to present us is first to better understand what is the immune profile of women at high risk to deliver preterm. This is the group with preterm labor and the group with PPROM. And she's going to compare this group with another control group with no symptoms or another control group that has symptoms, are contracting, but is at term. And the second objective is the most attractive from a clinical point of view, because she's trying to construct prediction models of delivery before 48 hours and also before 34 weeks of gestation to try to target well who is the group who benefit from our antenatal management. And she's going to try to explore clinical data, ultrasound markers, also inflammatory biomarkers. And for this reason, she's going to look for high resolution technology, as she's going to explain us, in a minimally invasive method, the maternal plat. So Maria, I hope that at the end of this thesis, we will have a better knowledge about the possibility to better predict who is the group who really benefit of our antenatal management, who is this group. If you, with your thesis and with your results, will help us to better understand this problem. Thank you so much.
Thank you very much for this very nice presentation, Teresa. To put it in its context. Now it's your turn, Maria, please.
Thank you. So I will present the main findings of the thesis, but before I start with that, I would just like to comment on why there's an Argentinian mountain range on the cover of a thesis in obstetrics. And the main reason for that is that I think that the silhouette of this mountain range looks just like a CTG curve. For those of you who don't daily look at CTG curves, this is what it looks like when a fetal heartbeat is registered and is normal. Now let's get serious. There are 4 papers included in the thesis. Number 1 and 3 are published, and number 2 and 4 are in our manuscripts in preparation. And I will tell you about these studies as we move along. The general aim of the thesis was to evaluate clinical parameters and immunological biomarkers as predictors for spontaneous preterm birth, both in symptomatic women with threatened preterm labor or PPROM, and in asymptomatic women in early pregnancy, just like Teresa explained to you. And PPROM is an abbreviation for preterm pre-labor rupture of the membranes, which means that the water has broken, and I will mention that abbreviation several times. So the first paper is called Preterm Birth, a prominent risk factor for low APGAR scores. It was published in 2015 in Biomed Research International. And the APGAR score is a fast way of assessing the well-being of a newborn child, where a low score is associated with morbidity and mortality. This was a retrospective registry study, including all 20,000 live births in Linköping and Kalmar during a 5-year period of time. And the aim of the study was to identify risk factors for APGAR scores below 7 at 5 minutes of age, and to identify risk factors for preterm birth before 32 weeks of gestation. A number of risk factors for low APGAR scores were identified: maternal short stature, overweight, and obesity, as well as several obstetric factors like nulliparity, previous cesarean section, multiple gestation, and a non-normal CTG at admission to hospital. But the most evident risk factor was gestational age at delivery, both post-term birth, but above all preterm birth, where the more preterm the delivery was, the greater was the likelihood of lower APGAR scores. In fact, delivery before 28 weeks had an odds ratio of 15 for APGAR scores below 7 compared to delivery at term. And risk factors for preterm birth before 32 weeks of gestation included, for instance, smoking and nulliparity. But the most prominent risk factors were multiple gestation with an odds ratio of 15 and preeclampsia with an odds ratio of 5.5. So to conclude study 1, a number of risk factors for low APGAR scores were identified, and the most evident risk factor was preterm birth. And the more preterm, the greater the likelihood of APGAR scores below 7. And the most prominent risk factors for preterm birth before 32 weeks of gestation were multiple gestation and preeclampsia. So now let's move to study 2. High sensitivity detection of inflammation-associated plasma proteins predicts preterm birth in preterm labor, which is in manuscript. Study 2 had 2 aims, and I will present them separately. The first aim of study 2 was to elucidate the cytokine and chemokine profiles in preterm labor and PPROM compared to antenatal controls and controls in labor at term. And to do this, a prospective study was conducted, including a total of 204 women. 120 women before 34 weeks of gestation were included with either preterm labor, 80 women, or PPROM, 40 women. And all these women were clinically assessed as having a high risk of imminent preterm birth, so they were hospitalized and treated accordingly. And furthermore, 44 women with normal pregnancies and subsequent delivery at term were recruited at an antenatal clinic, and these women were matched for gestational age with the women with preterm labor and PPROM. And finally, 40 women with normal pregnancies and in an early phase of active labor at term were also included as controls. And chemokines and cytokines representing different types of immune responses, Th helper 1, Th helper 2, Th17, B cell activation and inflammation, were analyzed in plasma samples from these women, and they were analyzed with multiplex bead assay, which is also called Illuminex, and ELISA for CCL18. So now we are comparing plasma samples from these 4 groups of women. And the same numbers, as you see here, are displayed in the table on the next slide. So here are the corresponding 4 groups of women, and the chemokines and cytokines that differed significantly between the groups. So these proteins represent Th2, Th17, and inflammation. So first we investigated if there was any difference between any of the groups, and where a difference was found, further statistical analysis was performed. And this table shows only the cytokines and chemokines that displayed significant differences. The others are not shown here. And we found a very complex pattern with several differences between the groups. So for instance, the Th2 associated CCL17 was higher in preterm labor and term labor compared to antenatal controls. And the Th17 associated CXCL1 was considerably lower in the antenatal controls compared to the other groups, and higher in term labor than in preterm labor, but there was no difference between preterm labor and PPROM. Pro-inflammatory CXCL8 was higher in term labor than in preterm labor, and finally, pro-inflammatory IL-6 was lower in the antenatal controls and in the women with preterm labor. So to conclude this, preterm labor and labor at term were associated with a more complex type of inflammation than previously thought, which involved both Th17 and Th2 associated immunity. And where there was no significant difference between preterm labor and PPROM, both these conditions showed higher inflammatory activity than the antenatal controls. And now to the second aim of study 2, which was to investigate if combinations of plasma proteins together with clinical parameters are able to predict delivery before 34 weeks of gestation and delivery within 48 hours in women with preterm labor. So and now we're studying this subgroup of 80 women with preterm labor and what happened to them. Well, not very many delivered very early. Only 21 of the women with preterm labor, that's 26%, delivered before 34 weeks of gestation. So if you look at panel C, this shows all the individual women as either a black or a red bar, and the women who delivered before 34 weeks are indicated by the red bars. And the gestational week at inclusion in the study is indicated below. So this means that the longer the bar is, the more time passed from study inclusion until delivery. So furthermore, only 14 of the women with preterm labor, that's 17%, delivered within 48 hours, which is indicated by the black arrows. So as you can see, all women who delivered within 48 hours also delivered before 34 weeks of gestation. Now, the chemokines and cytokines that were analyzed with the Luminex were not able to discriminate preterm delivery, while plasma samples now were also analyzed with a high sensitivity and high specificity method called proximity extension assay, by which a panel of 92 inflammation-associated proteins were measured. And plasma levels of 16 of these proteins were significantly associated with either preterm birth before 34 weeks or delivery within 48 hours. And there's a big overlap between the proteins, so they are virtually the same in the two columns. So this might be considered as a screening for proteins associated with preterm birth. So next, a discriminant function analysis was performed, including all proteins that differed at the significance level at 0.1, which 29 proteins did, including some of the proteins from the Luminex. And this was in order to find out which combinations of proteins that most accurately could discriminate preterm birth before 34 weeks and delivery within 48 hours. So this slide shows the ROC curves that were defined from the discriminant function analysis regarding delivery before 34 weeks and within 48 hours. IL-6, IL-17C, IL-10 receptor beta, and fibroblast growth factor 23 were most strongly associated with delivery before 34 weeks, and IL-6 and IL-17C with delivery within 48 hours. So the predictive accuracy of these proteins is shown by the blue dotted line, with an area under the curve of 0.88 for delivery before 34 weeks and 0.84 for delivery within 48 hours. Next, we added cervical length to the prediction model and adjusted it for BMI and age, which are the red lines, which gave a slightly better accuracy with an area under the curve of 0.90 for delivery before 34 weeks, with a sensitivity of 90% and specificity of 74%. And for delivery within 48 hours, the area under the curve for the combination model was 0.88 with a sensitivity of 100% and specificity of 71%. So to conclude, delivery before 34 weeks and within 48 hours after preterm labor was predicted with high sensitivity and specificity, but these promising results need to be validated in other cohorts. And now we're moving on to study number 3, plasma oxylipin levels associated with preterm birth and preterm labor, which was published earlier this year in prostaglandins, leukotrienes, and essential fatty acids. The aim of this study was to evaluate plasma oxylipin levels as a predictor for preterm birth before 34 weeks of gestation and within 48 hours in preterm labor. So now this starts to sound familiar, right? So we continue with a group of 80 women with preterm labor. And now their plasma samples were analyzed with high performance liquid chromatography coupled to tandem mass spectrometry regarding the concentrations of 67 different oxylipins, which are fatty acid metabolites that have important roles in inflammation. The names of all the analyzed oxylipins will be shown on the next slide. So it's a little bit busy, but I will try to explain it. So here are our oxylipins, and I hope that you who are watching have a screen that's big enough to see something on it. But here are the names of the oxylipins. And all these oxylipins are generated from precursor polyunsaturated fatty acids by different enzymatic systems, which are shown in the different colored ellipses. And the main findings of Study 3 was that the oxylipin 9-10-dehode was protective in relation to both delivery before 34 weeks and within 48 hours, whereas higher levels of the oxylipins 11-12-dehetra and 8-hete were associated with increased odds of delivery before 34 weeks and within 48 hours, respectively. And to conclude, in women with preterm labor, the oxylipin 9-10-dehode was protective in relation to preterm birth, while 11-12-dehetra and 8-hete were associated with increased likelihood of preterm birth. And although the associations between these oxylipins and preterm birth are very interesting and also novel findings, they were not strong enough to serve as a prediction model. So now to the last study, Study 4, early prediction of spontaneous preterm birth before 34 weeks of gestation by a combination of inflammation-associated plasma proteins measured by proximity extension assay, which is in manuscript. And the aim of Study 4 was now to identify plasma biomarkers in early pregnancy predictive for spontaneous preterm birth before 34 weeks of gestation. And now we performed a case control study with 46 women with spontaneous preterm birth and 46 healthy controls with normal pregnancies and delivery term. And these women were selected from a prospectively collected pregnancy biobank with plasma samples from both the first and the second trimester. And the plasma samples were analyzed with proximity extension assay, just like in Study 2. And from trimester 1, all study participants had available plasma samples, but from trimester 2, plasma samples were available from 31 of the women with preterm birth, but from other controls, which was a prerequisite for inclusion of the controls. So, like in Study 2, the same panel of 92 inflammation-associated proteins was analyzed with a proximity extension assay. And also, like in study 2, all the proteins that differed significantly between the cases and the controls in the respective trimesters were further analyzed with discriminant function analysis in order to find out which combinations of proteins that most accurately could predict preterm birth before 34 weeks of gestation. And then again, ROC curves were defined. And here are the ROC curves. So the combination of proteins that most accurately predicted spontaneous preterm birth had an area under the curve of 0.90. That's the blue line. And this combination included proteins measured both in the first and the second trimester, as well as the change in protein levels when comparing trimester 1 and trimester 2 samples. However, there was a dominance of trimester 2 proteins in this combination model. The predictive accuracy of proteins exclusively from the first trimester, that's the green line, was not as convincing, with an area under the curve of 0.76. So to conclude, a combination of plasma proteins from the first and second trimester of pregnancy was able to predict preterm birth before 34 weeks of gestation with high accuracy. But the predictive accuracy of exclusively first trimester plasma proteins was moderate. And future studies should focus on early prediction models to provide the highest clinical value, and by early I mean in the first trimester. So just a few concluding remarks. In these studies, clinical and immunological biomarkers of preterm birth were identified. Preterm birth was predicted at high accuracy by combinations of inflammation-associated plasma proteins. And one prediction model applied to women with preterm labor who were hospitalized because they were assessed as having an imminent risk of preterm birth. So thus the prediction model could be used to avoid unnecessary treatments, like Teresa mentioned earlier. And the other prediction model was for asymptomatic women in early pregnancy, and to be able to predict a high risk of preterm birth gives the opportunity to offer preventive treatment, which has better effect the earlier it is initiated. And although the predictors for preterm birth identified in this thesis are very promising, further studies are needed before they can be used in clinical practice. And now I say thank you for your attention.
Thank you so much for this nice presentation, Maria. Now we are looking forward to this very nice dialogue. Give the word to Teresa first then, please.
Thank you, Maria, for your clear explanation. I heard me. I don't know why. No. Okay, it's okay.
No problem.
I don't want you to see me as an opponent. Just see me as the person who wants your work will highlight today with all your family and your friends. But it's also my mission to ask you about your project. And I have structured my questions following the same structure you did in your book. So I will ask you some questions about the introduction, the overall problem, about the methodology, the statistical analysis, and we'll finally enter in detail into the papers, okay?
Mm-hmm.
Okay, so regarding introduction, except for paper 1, your aim with the rest of paper was first to explore the immune profile of women at high risk of preterm birth in comparison with a control group with no symptoms and with a control group of women in labor but at term. And the second aim was in women with preterm labor to predict who are going to deliver before 34 weeks or within 48 hours from admission. Mm-hmm. And for these two purposes, you explored the innate and the adaptive immune response profile in the maternal blood using different methodologies. So my question is, why did you choose these outcomes? Delivery before 34 and within 48 hours.
Well, this is, I understand the question because it's a very important question. And when you read different works in this field, one of the problems when you interpret findings, that different outcomes are chosen. So I'm aware of that, that it is a problem, but we chose 34 weeks because of the strong association with neonatal morbidities before that week, and also because the guidelines recommend that corticosteroids are given before 34 weeks and not after, really. And also since the full effect of corticosteroids is achieved after 48 hours. That was the other reason for us to choose 48 hours. But of course, you could also choose delivery within a week, as you have in your work. But actually, in our study, it turned out that it's virtually the same in our study, because there were 9 women who delivered within a week, and everyone but one delivered before 34 weeks of them. So sorry, that was wrong. But there were
it's okay. It's okay. Your answer was perfect. So it was because steroids administration. So it's really nice. It was what I wanted to hear. So. What is the prevalence, Maria, of spontaneous preterm birth in your clinical setting? Do you know that?
Problem?
The prevalence, the rate.
Before 37 weeks?
Yes.
I'm not sure I have the latest rate, but
approximately.
It's approximately like in Sweden in general, so it's about 5.7% or something like that.
Mm-hmm. And can you hypothesize why the prevalence of spontaneous preterm birth in Sweden differs so much from that report in other countries, such as the African or United States? Why do you think it's a problem of diet? It's a problem of ethnicity, the policy of IFB?
Sorry, I didn't hear the last part of your question.
No, if you can hypothesize with me, why do you think that the prevalence in Sweden is so low in comparison with other countries? If it's a problem of diet, it's a problem of ethnicity, or your policy in the IFB is different from other countries, so what do you hypothesize?
Mm-hmm. Well, I think the biggest part of the explanation is our antenatal care. Well, first of all, it's very it's the same for the whole country, and almost every woman attends it. So that's I think we have the opportunity to identify a lot of women who are at risk for various complications during pregnancy. And then we're also a highly developed country with fewer health problems than a lot of other countries. The countries that have the highest preterm birth rates are in a completely different situation, and probably have a lot of other reasons for the cases of preterm birth. We have no malaria. But a diet, that's really interesting. And of course, also since one of the studies is about oxylipins, but that's difficult to say, I think.
It has been shown. There is from Norway. I think that it was Bo involved as well. There is epidemiological study that reports that the Norwegian women who really eat a lot of probiotic products have lower rate of late spontaneous preterm birth. So maybe diet is involved in some way. Mm-hmm. Your healthy diet in the Nordic countries. Another question.
But I think maybe that goes hand in hand with socio-economic factors as well.
Sure. Mm-hmm. One of the risk factors of spontaneous preterm birth is smoking, and you have shown that in your findings. What do you think is the mechanism that explains why smoking is considered a risk factor? Do you know how can smoking act just to increase the risk?
It's probably due to oxidative stress. I would guess that affects the membranes and starts an inflammation.
An sterile inflammation. Excellent. In your clinical setting, do you screen for spontaneous preterm birth?
No, we don't. No. Only in women with previous preterm birth, okay. But not no general screening.
And in symptomatic women, in women with preterm labor, what are the clinical tools you use for decide to admit a woman or not?
Well, it's only to evaluate the contractions, manually and with CTG, of course, and then assess the cervical status. And that's it.
But you decide to admit or not based on the cervical length as well?
Sorry?
The cervical length? You use the cervical length to decide the admission of the women? Yes. Okay.
Yes, but I mean, it's not a very strict cutoff. I mean, the clinician at UTE always makes a clinical assessment of the whole situation, and of course also other symptoms like is there any fever, discharge, bleeding. But if it's strict symptoms with only contractions, then of course the cervical status is important.
So why do you think that the cervical length can be useful?
Well, it has been shown that a short cervical length in preterm labor is clearly associated with a higher risk of subsequent preterm birth.
And in the opposite, no? If it's a long cervix, the chance to deliver is very low, no? The negative predictive value of the cervical length is very high as well. So help just to decide, no? The clinical decision if it's needed to admit or not, maybe, no?
Yeah.
Not because of the positive predictive value that is not very high, but most because of the negative predictive value, no? And do you screen also in women with PPROM? What is your clinical approach?
Sorry?
In women with PPROM, do you also check for the cervix, or did you do any other tests?
I couldn't hear you very well. Can you repeat the last?
Yes, in women with preterm labor, you use the CTG, the symptoms, and also the cervical length to decide if a woman has a risk or not to deliver. And your decision to admit the woman is based on that. In PPROM, what are the tests that you used to do in women with a?
Well, they are at a much higher risk to deliver, and we showed that clear. I didn't mention that, but in our study, 85% of the women with PPROM delivered before 34 weeks. So just having PPROM is a reason for being hospitalized, at least until the next day, so we can evaluate if there are any contractions that are starting during this period of time, and they are screened for infection. But that's not part of the decision whether the woman should be hospitalized or not, and they are also put on antibiotics.
So the problem of PPROM is the infection, no? So this is the most relevant, and the infection is related to preterm birth. This is why all the women are admitted. Perfect. And so regarding this problem, the infection and the inflammation, do you know the prevalence of infection if it's similar in women with preterm labor and in women with PPROM? So the problem of infection is more frequent in PPROM or in PTL?
In PPROM.
In PPROM, okay. Do you check for infection in your hospital?
Yes, we check for chlamydia, and we do a GBS cultivation.
Okay. And regarding the inflammatory response, the immune response, in your findings, you are testing the maternal blood. But do you think the inflammatory response differs according to the biological compartment you are sampling?
Well, that's a very interesting question, because you could argue that we're far away from where the action happens. But it has been shown that what goes on in the circulation is, what you can find in the circulation reflects what happens on, well, let's say, distant sites. It should be possible to find biomarkers in the circulation, I think.
This is what you have shown.
Yeah.
Mm-hmm. This is what you have shown.
They
okay.
need to be validated.
Mm-hmm. You need to validate, yes. About methodology, Maria. So can you briefly explain to the audience that are not familiar with this methodology, what are the pros and cons of the methods that you have used? I don't know that you will go into detail about the mechanism, how it acts. No, just what is more translational. So from your perspective, you did work, you test some methods, but now you want that it will translate into clinics. So what do you think is the best method to be translational? If you can clarify me that.
The proximity extension assay that we used is a very high sensitivity and high specificity method. Because do you want me to explain how it works or not? Yes.
Not in detail. Only no. Yes, briefly.
The detection of the analytes is based on the fact that two different antibodies bind to different epitopes of the analyte, and these antibodies have a short chain of oligonucleotides attached to it. So the reason that the method is called proximity extension assay is that the antibodies need to be in close proximity, so the oligonucleotides can bind to each other. If they're not, then there's no binding, and then there will be no detection, because what then happens is that a PCR method is used to amplify those oligonucleotides. So that's why it's such both a high specificity and sensitivity.
And do you know if it's a rapid test? Do you know if the result is rapid?
Not at present, but since it is PCR based, it could be possible to develop this method so it might be able to have it bedside. Because I mean, in these settings, you need a fast answer.
Mm-hmm. Perfect. And why do you think it's important, the normalization of your data? Because you normalize your the levels of the proteins. Why do you think it's important? You did a lock. You did a lock unit in the levels of the parameters that you analyze.
Yeah, that's how the method works, and that's to you don't, when you get this sort of answer from the analysis, it's not presented as concentrations, but normalized protein expression, which is a log 2.
This is just to minimize the variation, no? To try to avoid the outliers. Exactly. Mm-hmm. Mm-hmm. Perfect, Maria. Let's move to a statistical analysis, okay?
Yeah.
So in paper 1, you compare the antenatal factors before delivery according to the occurrence of a low APGAR score at 5 minutes below 7 or not. And you use the mean and the standard deviation. So did you test for normality distribution? Why did you use the mean and not the median?
Well, I don't think we tested for normality distribution, actually.
Maybe it was not needed because your sample size was very huge. So it was 21,000. So you can assume that there is a normality distribution. But if not, there are some tests that you can use to do that. And this is in contrast, in the other papers, you use the median and the interquartile range. And do you know why in that case you did not use the mean?
Sorry, in the...
So when you are talking about maternal characteristics in a huge sample size, you can assume that the data is normalized, so show a normal distribution. So you can use the mean and the standard deviation. However, what happens with the concentration of proteins or metabolites is that you don't know if it follows a normal distribution. So you use non-parametric tests, and this is why you use the median and the interquartile range, and you did very well in your papers. But this is the difference. No, in maternal characteristics, you can assume some normality of your data, but when you are talking about biochemical parameters, it's much better to use the median and the interquartile range. So you did well. And to help to the audience to understand your results, you are looking for a sort of proteins, no, that combine with clinical parameters to better predict your outcome of spontaneous preterm delivery before 34 and 48 hours, okay? So you need to construct a model that will include those parameters that better predict your outcome. You follow me, no?
Yes.
So how did you do that?
Well, first we did a kind of, let's call it a screening test with a Mann-Whitney U-test to see just which proteins that were associated with the outcome. And then we included all proteins, but actually at the significance levels of P 0.1 and did a discriminant function analysis, which I cannot at all explain the mathematics in this, but it compares the standard deviations of the the means in this case, in this discriminant function analysis. So in this case, if the proteins were not normally distributed, we had, in some cases, they were transformed to the natural logarithms to get a normal distribution. So in this case, that was done.
Okay, and with this logistic regression analysis, you got
discriminant function. Yeah, discriminant function analysis.
Okay.
Was that, yeah.
How did you select the best combination? So how did you decide that these proteins that you mentioned were the best, who better fit your outcome?
That's from the discriminant function analysis, which it's a little bit like logistic regression, and actually we didn't write that, but we also checked the results with we did a logistic regression analysis as well and got the same results. So well,
no, but just to select, I understand, but yes, okay, it was like a rock curve. It's a rock curve what you did. Yeah, and with the rock curve, you select what was the better cutoff.
Yes, that's what I mean. Yes,
and this better cutoff, what were why did you decide that it was this and it was not another one? You were based on some diagnostic indices.
Yes. We reasoned that a high sensitivity was very, very important. So we wouldn't discharge any women home that would later, that perhaps would give birth at home. So, and I mean, then it comes at the cost somehow. You have to choose if you want to prioritize a high sensitivity or a high specificity, because very rarely you can have both.
Yeah. So you prioritize with the high sensitivity, of course, not to discharge home anyone who was going to deliver.
Mm-hmm.
Perfect. So this is what I wanted that you would say. You say perfect. This is Maria. In your thesis, there are some points that you says. Now you have explained me very well, but in the book I read that you choose this cutoff based on the positive predictive value and the negative predictive value. And I think it was wrong because the positive and negative predictive value depends on the prevalence. If your prevalence changes, this predictive value also will change. But sensitivity and specificity doesn't depend on prevalence. So now you answered perfectly well. But in the back, it seems that I didn't understand quite well. I thought that you thought that the cutoff was based on the negative predictive value and not. The cutoff must be based on the sensitivity, as you mentioned. Sure. Okay, so let's forget the statistics now. and let's move to the papers. Okay, it will be easy. It will be easy, Maria. So there are two papers that have been already published, and there are two papers that are unpublished yet. And what about these unpublished papers? Are they planned to be submitted or?
Yes. The second paper has been submitted several times.
Yes, okay, okay.
It is still not published. And now we're thinking actually of dividing it into two because we have plans on new proximity extension data with a second panel. So we're thinking about that. And study 4, I think we wrote explicitly there that we're actually waiting for more data, and then we will submit it.
Perfect. So in the paper 1, okay, huge number of infants, 21,000, born at a secondary and tertiary level hospital. 99% of infants had assigned APGAR score, so really, really nice. And your aim was to identify which antenatal factors before delivery were predictors of a low APGAR score at 5 minutes, no? I don't see this paper will match too much with the rest of papers. Can you explain me the storyline, the connection, the link between these 4 papers?
Yeah. Well, this is actually what is, well, at least in part, started all, got me interested because we were surprised to find that preterm birth was such an evident risk factor for low APGAR scores. And some say, well, that's just completely what you would expect. But when you talk to pediatricians, they don't agree. So then in paper 1, when we found that preterm birth was such a strong risk factor for low APGAR scores, we also wanted to know if we could identify risk factors for preterm birth in the material at hand. So it wasn't intended for that to start with, but we found some risk factors that have been shown before. But maybe it's, I don't know where I'm going. Anyway, this got me very interested in preterm birth, and then I contacted Jan, or he contacted me. I don't really remember. We had worked together a long time together before, but a very long time ago, and with completely different things.
Well, okay.
Yeah, I know that the first paper is a little bit kind of squeezed in the thesis, maybe, but yeah, there is
the beginning of your research, the beginning of your research career.
Yeah.
So, in your clinical practice, Maria, is this APGAR score below 7 at 5 minutes a clinical criteria to decide an infant admission or a closer vigilance?
Sorry, but
if it's useful in your clinical practice, so if this outcome is used by pediatrician to change the management of this baby, if the baby needs more vigilance or maybe needs to be admitted.
Well, not only the APGAR score, but of course it's a very important parameter that's included in the decision how to take care of the infant, and it's actually what defines birth asphyxia by definition, which is kind of strange, but it is so. Yeah.
So you said that gestational age was one of the strongest factors for a low APGAR score.
Mm-hmm.
How do you think it can contribute the neonatal intubation in extreme premature infants? So you know that if it's a baby who is born maybe at week 24, maybe this baby will be intubated in the delivery room.
Yeah.
How can affect to this APGAR score at 5 minutes?
Well, yeah, of course. That's a very, very good point of view, because you do the intubation before 5 minutes, so yeah, you can't really.
This is
but they are so few, so
yeah. But this is something to consider, because you said that the extreme preterm birth, no, is one of the strongest predictors. Okay, but there must be maybe a bias to be considered that, no? This is why it's important also parameters that you mentioned, no, the pH, no? So this is not only the APGAR score that pediatricians use. There are other variables that use to assess the well-being of the baby, no? In your results, you found that maternal height, a small woman like me, I'm small, or nulliparity or the prior C-section were risk factors for a low APGAR score. Can you hypothesize the mechanism behind that? I know that you will not know. It's just that you can imagine, but I don't expect an answer.
Well, I think that maternal height is important. I think it's really, really interesting, but I have no answer. It would be very interesting to try to find out more about it. But it might be associated with socioeconomic factors or ethnicity. It would be interesting to check if whether these women, whether it's more common that they need the help of a professional translator, perhaps, because maybe, I don't know, but I mean, there are also a lot of short women who speak Swedish, because I think that communication problems, and it has been shown, communication problems are a risk factor for a lot of things in obstetrics. They are at women who don't speak well Swedish in this case, but Spanish in another setting, that they are at high risk for stillbirth and a lot of other things. So it has to be something there, but I mean, it cannot just be the size of the pelvis that matters. It cannot be. It has to be something else. And I think I wrote that also as a reference that short stature has also been associated with, no, I don't find the words, with substandard care. And then again, I think that there might be a communication problem, but we had no possibility to adjust for ethnicity in this study. But I think it's intriguing. And about previous cesarean section, I don't know really. I mean, most of them have a spontaneous vaginal birth, although there's quite a high risk for cesarean section, but mostly not because of fetal problems.
Maybe, Maria, there must be a bias because you did not consider other intrapartum variables related to a low APGAR score. And maybe this woman with a prior cesarean section, maybe she had intrapartum fever or maybe meconium. And it was not only because of the cesarean, something happened intrapartum, no? And you have not recorded that, so you don't know. So probably there is not only because she has a prior cesarean, maybe she has more risk that in the intrapartum something will happen, no? And it will contribute to the low APGAR score. I missed these intrapartum variables. It was not possible to record them.
No, we had only admission CTG. I think this was done quite a few years ago now, but I think now it's possible to, maybe I'm wrong, to get data on oxytocin augmentation. But I'm trying to look at an expert here in the audience, but I don't know if it can be extracted from the database or if you have to. But that would of course be interesting.
This is the same what happens with the occurrence of preterm birth. That there is one variable that I really miss, and this is if there is a history of preterm birth.
Yeah, I know, and that's of course that's very much of a limitation. But this data is not recorded, so that well, then you have to check every medical record, and that's not possible with 20,000.
To do that. And finally, with this paper, how do you think these findings that you observe can change your clinical practice? Are you is able to modify something?
Well, of course, smoking. People have to stop smoking. That's the single most valuable thing I think that we found. But this is also known before, and quite a lot of effort is put in at the antenatal clinics to help the women who smoke to stop smoke. But it's not always very easy.
But at least it's an intervention, no? A primary intervention. Yeah. Okay, let's move to the paper 2. High sensitivity detection of inflammation-associated plasma proteins predict preterm birth in preterm labor. For groups, there are 3 preterm birth, defined as preterm labor or PPROM, a control group with normal pregnancies without symptoms, who are going to deliver a term, and another control group, normal pregnancies in labor, a term. The first thing is that I see a bit strange, this definition of 3 preterm delivery. It's a strange definition, no? Because there are preeclampsia, placenta previa, cervical insufficiency that might be considered also risk factors for 3 preterm delivery, no? I don't know if I have used this term, but I understand that it's difficult not for the term preterm labor and PPROM, how you consider that, no? And you use this term, but I don't know if it was very appropriate or not.
No, I think you're absolutely right. It's confusing, and since it's not published yet, I think that we should change that when we rewrite it, because it's and it also comes from. It's a bit of a I think language confusion thing. Also, that we tend to say threatened preterm birth in Swedish, but I agree it's confusing, and I also think that we should change it.
So at the beginning of this talk, you told me that in PPROM the prevalence of infection is higher than in preterm labor. However, you did not observe differences in the concentration of proteins between women with preterm labor and PPROM. What do you think? This is. Have you any explanation for that?
Well, they are probably, both of these groups are probably a little bit more prone to inflammation. But I mean, we were surprised that that there were no differences between these groups. We would have expected actually perhaps to find more signs of inflammation in the preterm labor group than in the pre-prom, although perhaps there's infection in the pre-prom group, but since they're not in labor, maybe the levels of pro-inflammatory proteins would be lower in the circulation.
Or maybe, Maria, I don't know, maybe if you have stratified by gestational age at delivery, imagine that you consider a group delivery 7 days, delivery more than 7 days, and you compare PTL and PPROM. Maybe there, in the group of PTL, who is going to deliver before 7 days, maybe you see the differences, no? Because here you consider all your PTL or your PPROM, regardless of the latency to delivery. Yeah. But maybe if you take into consideration, no, the time to delivery, maybe you would have seen differences. I guess, I don't know.
Yeah, but the Luminex panel. But that was only done for the PTL group when we compared delivery within or after 2 days and before and after 34 weeks, not for PPROM, of course. Yeah, sorry, I misunderstood.
The same with the. It's interesting that you observed that there was a higher inflammatory response in women in labor at term than in women with preterm labor. Here, I think it's something similar, no? Maybe if you select the PTL who is going to deliver in 48 hours, maybe these differences would not have been so evident, no? What do you think?
Yeah.
Because you said, no, that 60% of PTL deliver at term.
Yeah.
So you consider all PTL, okay, it could be normal that you will not see differences with the woman in labor at term. But if you select the PTL who deliver preterm, maybe these differences would have not been so evident, no? Maybe the inflammatory response would have been similar.
Yeah, that's possible.
It's possible, okay. Another consideration is just to adjust for multiple comparisons. When you have multiple comparisons, such as you show in the panel of proteins, significant differences can be done by chance, and there is a way just to try to correct. I don't know, you know the von Ferroni correction?
Well, I've heard it, but we haven't used it. Yeah.
Because I think it's something I suggest that maybe you can explore, because you observe differences between groups, but you check 13 proteins at the same time. And I calculate the risk. In your study, there are 13 proteins, and every protein have an alpha risk of 0.005. Okay, so there is a probability of 48% that by chance any of these 13 proteins will have different means. So I suggest, Maria, that you specify the p-value, but you need also to correct for this von Ferroni correction, and it's very easy. So you just need to multiply the p-value for the number of comparisons, and it's enough. And then you will see if your differences still remain or not. Do you understand?
Yes, but
it's just to perform a post hoc correction. I don't know if it makes sense. It's just that I saw that.
Yes. Yes, but I mean, we have, of course, there were a lot of proteins, but we checked every protein at the time. So we checked one protein at a time, and then compared the 4 groups.
But when you did the analysis, in your analysis, you did not include all the proteins together?
No, one at a time.
One at the time.
And then compared every single protein between the groups. So we haven't put in like all the proteins at once.
It was not. Okay. Perfect. What I explained was when you run simultaneously all the analysis.
Sorry.
What I wanted to explain is that you can use that Bonferroni correction if you run simultaneously all the comparisons together.
Okay.
Okay. So let's see. In your results, you found that gestational age at sampling was different in women with preterm labor or PPROM and in women that you consider your control group and not had symptoms. You follow me? Yes?
Yeah.
So here I see a potential bias, Maria, because you don't know how the proteins, how is the level of these proteins along gestation. So if you observe differences in the concentration of these proteins and gestational age at sampling is different, you cannot exclude that maybe the differences is because you are sampling in different moments. I don't know if you follow me. Yes?
Yes, I understand what you mean. But the intention was to match the control groups, the antenatal control groups for gestational age with the PTL and the PPROM group. But as this was done in practice, we had to kind of present to the midwives at the antenatal clinics that now there are this and this many women and this week, and can you please find us controls? And then in the end, it turned out that the control group was gestation age matched really only with the PPROM women and not with preterm labor women. But the difference is not very big, but of course it can be a bias. I think
it's just that because in your model you adjusted for maternal age and BMI.
Yeah,
so maybe it should have been possible also to adjust for gestational age at sampling.
Yeah.
Perfect. I have some questions, but you answered me, so okay, I go quickly. And at the end, in the model, you have included different variables, but there is a rule that says that in a prediction model, you should include one variable for each 10 outcomes. I don't know if you follow me. So your outcome of preterm birth below 34 was 26 women. So in your final model, you should have been include only 2 or 3 variables, and you include more.
Okay.
So maybe you try to validate, and so maybe you could even try to be more restrict when you enter different variables. No, because at the end, if there are too many variables, I think there is a bias. Just for replication and for validation, it's much better that you will include one variable for each 10 outcomes. This is something that it's like a rule. Just a suggestion. Okay. A suggestion. And okay, the last question was regarding the clinical translation, but you tell me, no, that still there is not a bedside. This multiplex immunoassay is not ready for bedside. But okay, you think that maybe in the future it could be used as a screening tool, no? Maybe do you think so? Perfect. And finally, the paper 3, plasma oxylipin levels associated with preterm birth in preterm labor. Here, something similar, very, very nice, no metabolites. And also you did a logistic regression just to explore the oxylipins that were independent risk factors for the outcome delivery before 34 weeks and within 48 hours. And you observed that there were some oxylipins that have a protective role and another that have a harmful role. We know that the metabolic expressions can be interfered by several factors such as treatments or maybe diet. I don't know if you have considered, if you have taken into consideration the potential effect of the treatment that was receiving the women or maybe the diet. I don't know if you take that because the metabolism, no, metabolites can be interfered.
Yeah, well, if you should do a very, very strict investigation about oxylipins, the plasma samples should be taken at very standardized occasions, preferably after, well, I don't remember exactly, but a number of what's it called, fast, when actually you haven't eaten. Mm-hmm. But this is not the case here, so that's a limitation because I mean this is an emergency situation. So the blood samples have been taken or have been taken all around the clock, and so it's not standardized at all in relation to when the last meal was, and. Of course, what kind of diet you're on, if there's any special type of diet, of course, could have an impact on the oxylipin levels in plasma. That cannot be ruled out. And we have no real possibility to check for that. I don't know if BMI matters regarding plasma oxylipin levels, but it might. But we chose actually not to adjust for BMI because we wanted to see, wanted to study the oxylipins themselves because this hasn't been done before. Mm-hmm. So if you adjust for too many factors, then that's also a risk that you kind of over-adjust.
Mm-hmm. It was very interesting your observation, no? That somehow oxylipins could have a protective effect. And in the book you said that when there is a deficiency of omega-3, it seems to be an increase of the rate of spontaneous preterm birth. So do you think that your findings can explain this clinical evidence?
Well, perhaps. I mean, it could be an idea for a type of new study, but again, it's different to study the group with preterm labor because I mean, it just suddenly happens, and you can't really know who will be one of those. So I mean, it's a lot more difficult to study than to study. Well, if you do a longitudinal study from early pregnancy, where you decide to include, the number of women that are needed to show what you want to show, but it's a lot more difficult here. I don't know if I answered your question. Somehow got lost.
No, of course, no, but
really
this is just exploratory study. I understand. I understand, but at least you see a connection, a virtual connection, no?
Yes.
Could be. Mm-hmm. And finally, Maria, the paper 4, early prediction of spontaneous preterm birth before 34 weeks of gestation by a combination of inflammation-associated plasma proteins measured by proximity extension assay. So here you use your biobank and test samples at first and second trimester. And also you choose a group of women who at the end deliver preterm, and a group of control group that deliver a term. And also did a prediction model for spontaneous preterm delivery before 34. And you also found that the association between first and second trimester seem to better predict the outcome of a spontaneous preterm delivery before 34, no? With an area under the curve of 0.9. So very, very nice. For that, you did a sample size calculation, and you hypothesized that you would observe a 40% of difference in the immunological profile between the group who delivered preterm and the group who delivered at term. And why did you select this 40% of difference? Did you take in from other papers from previous? Because 40% is a huge difference.
Yes, but there's in our group. Now I'm looking in my brain for words again. In the group, there's a lot of experience from studying other pregnancy complications like preeclampsia. So that's really from that field that these percentage numbers come from.
Perfect. And finally, Maria, so people who check or who screen the cervical length at second trimester and observe a short cervix start with secondary prevention with progesterone or maybe cervical pessary or cerclage, so on. So according to your results, you have found that the selection of biomarkers at first and second trimester could predict the outcome of a spontaneous preterm delivery with a high accuracy. So what would be your clinical strategy? So according to your findings, you think that, I know that it's not time yet, but how can you imagine your findings could be translated into a prevention strategy? I don't know if you understand.
Yes, I understand. No, that's an interesting thought, of course. But it would be well, if we have to validate it. It's a long way to go, but let's say we do that. Then I think it's quite plausible that perhaps it's not as easy as just if we identify this type of high risk in this group of women. Perhaps different women need different types of secondary prevention, and so I suppose that it needs to be studied a little bit in subgroups, and perhaps you have to consider other variables as well, like perhaps BMI or ethnicity or smoking, but it would be very interesting to do a study of where you a randomized study where you test, for example, vaginal progesterone and see if it has any effect. And it's also interesting that perhaps aspirin has a preventive effect also for preterm birth.
So that's all, Maria. Excellent work, excellent presentation. You really defended very well all my questions. And now you are getting the tip of this academic iceberg. So what is your research plan in the future? Have you any plan for tomorrow?
For tomorrow? Tomorrow I think I'm going to sleep a little first, but then when my brain is on again. No, but there are several interesting things to do, and actually one project that was starting, that was in my plan for my PhD studies, but it's not in the thesis. We we have blood samples from women with previous preterm birth who are very, very well defined, and our initial plans were to do genetic studies of some kind. And I think that's really interesting, and could also lead to perhaps new treatment options, perhaps. And also, of course, I want to finish the studies in this thesis that are not published yet, and we have new data from the proximity extension assay to look at. So that's really interesting. Yeah.
Perfect, Maria. So I finish. I don't know if Jan wants to continue or.
Thank you very much, Teresa, for this very nice and thorough opposition. I don't think you have missed very much, but anyway, we have to go on to the assessment committee, and maybe we will have some more questions. Would you like to say something before? No? Okay, then we'll continue to the assessment committee, and I would like to ask Bo Jakobsson first to put his questions, please.
Yes, if I get access to the camera, you can see me as well. It's off. It's off from the moderator, from the host.
We're fixing it, I think.
That's good. Yeah,
we speak. It's on the way.
Yeah, that's it. Yeah. So thank you, Maria. Thank you so much, and I'm so happy to have you in this community, and that you have done this work, and you have really contributed with your effort into the preterm delivery kind of community of people working here, and I've followed you during the years, and it's been very happy to see your development. And I also had the opportunity to be a part of the halftime control, and I'm very happy to see that some of the kind of suggestions that we brought up there have been that you have done. I will soon pick up one of those things that I think that partly comes from there. And of course, you understand that most of my comments have already been made by Teresa, because we have worked so much together over the years and have the same perspective. So I think that very importantly, the phenotypical definitions with the kind of mass significance possibility to address this, and the other thing is also that some of the studies is not yet published, and you say that validation needs to be done. But some of these findings you have, it's extremely high area under the curves. I mean, if it turn out to have that area under the curve, it will be really helpful for us in the clinics. Can you comment on that? And I mean, it will have a huge impact if you can validate it yourself, and it will have much more kind of impact in that. Do you have samples for that, or what do you think about that?
We don't have samples to test in another cohort ourselves, unfortunately. But from what I've understood, there's always a risk that there might be kind of overfitting when you do analysis like this, and that if we test our discriminative or prediction model in another cohort, it might turn out that it's not this good. I hope that it will be a prediction model that can be useful, but perhaps I mean, we can't really hope to have these kind of numbers, perhaps.
If you had redone your thesis today, and partly you have the opportunities since 2 of the papers not published yet, what would you have done differently?
Was a question that I should have anticipated, and I would have an answer like that, but I don't. But,
you can think about it.
Okay. Well, in study 2, where we included women with preterm labor, it might have been a good idea to really have a strict cutoff for cervical length, because it would be perhaps easier to compare with previous studies. On the other hand, I think that the women that we have included reflects the real situation. The reality. This is how difficult it is, and some. I'm hesitant if I would have done that part differently. And you were saying something else.
We can move on. The one of the things that I like very much in the book, and it's also in paper 2 and 3, is the new figure. It is in your slides, and it's in page 62. It's the one that is figure 1, I think, in paper 2, and it's with the red and black bars.
Yeah.
And I think it's quite illustrative. I think it's a very good way to show what we are working for, and I think that you, in a very good way, summarize this in the thesis. Do you remember a little bit, and for the audience, explain what? Maybe you have the slide. Can I share, or can I? Do you have it?
Yes.
In your former slides.
You mean that one?
Yeah. So figure number C here. It seems in a way simple to identify the red bars, because they are really short, and the black one is very long. Can you explain a little bit of this, and what is why is it so difficult to pick the red bars from the black bars already from the beginning?
Well, they present with the same symptoms. These women, they seem to have very painful and contractions on a regular basis, and they have cervical change in one way or another. And I mean, if they present with these symptoms very early, there's such a huge risk for the infant if we don't treat the mothers. So I think that's where the difficulty is, really. Maybe I'm not answering your question now.
I changed the question a little bit, so maybe that. But you had a very nice explanation of this, because you see it doesn't matter so much what kind of outcomes you have, number of days to delivery, or if you set a pregnancy week, the difference will not be very much different. Do you understand what I'm aiming for? It's pretty much the same patients. It's pretty much the same patients. Those
that the ones that deliver before 34 weeks and within 48 hours. Yes.
Yeah. So that is one of the differences that you can see, because you have very few that really have a start with contractions and not delivering very rapidly here. So that is a specific part of you, and I think it's quite universal. Maybe not that extreme that you see. You and Teresa discussed also what would be the best outcome in a study with women who comes into delivery ward with signs of giving birth preterm. Would it be less than 7 days, or would it be less than 2 days? What is the most relevant thing?
Well, I don't have an answer really, but some argue that within 7 days is a better outcome to study because. Well, and then again, we come back to the corticosteroids and their effect.
Yeah, but then I believe it's less than 2 days, because that is the issue that we want to do, because we.
Yes, but then some argue that you should perhaps repeat the doses of corticosteroids, that it has an effect for about a week, and if the woman is not going to deliver within a week, then we don't have to give it at all. But there are counter argues as well, I think.
Yeah. On the other hand, I really believe that we use too much corticosteroids, and there's a lot of them also that doesn't get corticosteroids. So I believe that it's important to have this good biomarker, or what you think. But to really, I for my part of, we have really covered most of this, and I think that you have a very good broad background to do whatever you want in this area after, because you have registered study, you have studied women coming to delivery ward with signs of preterm delivery. You have also tried to identify women in early pregnancy with impressive figures, but it needs really to be validated, and also a complicated kind of model that you had in paper 4 with also with samples both in first and second trimester. So thank you so much, Maria, for this.
Thank you.
Thank you, Bo. Can I ask Jorma to come forward and ask his questions, your questions?
Yes, thank you very much for a very interesting discussion and a nice presentation. And thank you also for explaining the picture you have on the front. It's a very refreshing presentation of a thesis, I think. I thought it was because it's a very, very healthy place to go. It's a very windy place and beautiful nature. So it's good for those that need fresh air. But thank you for a well defended thesis. I enjoyed it and I learned plenty. This is a bit out of my scope, but a few things I could understand at least. Let me start by asking you, in Sweden, when we have these preterm labors, is it known which, let's say, 5 major infections that are involved in the preterm labor, if one have to grade the ones that are involved?
Oh, to grade them? No, I don't know. No, sorry. Now my brain is dysfunctioning, as I've already mentioned. I think I've written about this in the in the book, so I should be able just to answer.
No, because my point really is, if you early on, when you meet these women, when they come to the maternal ward, if you already then could treat them and prevent these 5 major difficulties, let's say flu might be one of them, and then you have some, you said chlamydia is something you screen, and maybe mycoplasma. Could it be that you by exactly. that get the impact on the preterm labor?
Well, studies have been done to treat bacterial vaginosis, which is a risk factor for preterm birth. But unfortunately, they don't have any promising results at all. They don't decrease the risk of preterm birth. So I think, and I think also there's a difficulty, especially with GBS, which is one of the bacteria that are involved in preterm birth. Even if you treat it at some point, it's very common that there's a reinfection. So then I think it would be very difficult to find the optimal time to, but both to screen for the infection and when to treat it. Yeah.
If there, let's say, I mean, influenza, for instance, there are vaccines. If there would be a vaccine for GBS and maybe mycoplasma and chlamydia, at least they are on the way to be researched on, I know. But if they would appear, would they be on the pipeline to be offered to women before giving birth? Would you see that as any?
Yes. I mean, that would be an enormous health benefit for society. If you could vaccinate against chlamydia, you would get rid of a lot of problems in gynecology. So that's a good idea from a not just from this point of view, but from others as well.
Yeah, good. Thank you. Well, my remaining questions are a bit more technical. If you now look at the assays you have used, you have this Luminex analysis method, and then you have the PEA that seems really superior in sensitivity. Would you throw away the Luminex now? It's not meaningful to use it? It's too unsensitive?
No, I don't think so. But the thing with the proximity extension assay is that there are panels. So if you have a clear hypothesis, I think it's better to do a Luminex with a few analyses that you want to explore. But if there's a hypothesis-driven question, then I think the Luminex is better, because you can choose your analyze in another way, and you don't get a lot of data that you're not really interested in, and it doesn't cost as much. But with a more exploratory approach, then I would say that the proximity extension assay is a lot, well, it's superior.
Do you know if the Luminex analysis assay you used is the best on the market? Is it the most sensitive that is available?
No, I don't know. I'm sorry.
No, it's not easy to know. One needs time to test them all to find the most sensitive one, and that costs also both time and. But then my question is, when you collect the samples, you discussed with opponent the blood sample, or, well, the most preferable material is danger to collect. But isn't there any more material you can collect from individuals that you need to test?
Well, cervical fluid has been tested, or vaginal fluid, but it's a lot more tricky to do that in a standardized way than to take a blood sample. Yes, and also it would probably be possible to use the proximity extension assay if you have, because you need very little, very small volume, just 1 microliter. So that perhaps you could retrieve a vaginal sample, but then again, from exactly where, to do this standardized in a multi-center study around the clock is really difficult, I think.
Urine? Would urine be a possible sample material?
I don't know how much that would reflect preterm labor, really. If you can find biomarkers in urine that would be predictive, I don't know. I don't know.
Because I was just thinking that one gets worried here because one had to be invasive every time one takes a blood sample. And I suspect that the markers you have discovered, they might have diurnal variations. So if you collect the sample at night from the same individual and then in the morning, it will vary, perhaps sometimes very dramatically. Would you have any possibility to collect from the same individual, let's say at 4 different time points during 24 hours and run the assay just to see that you are not in a, let's say, low period in the mornings and the maximum sensitivity would be in the afternoon or in the night or something like that? Or is that done already?
In the context of preterm birth?
Yeah, because I see you have pointed out this IL-6, 17, IL-10, RB, and the FGF, and then this oxylipids. Are they dependent on when during the day you collect the sample?
Yes, they are. Yes, so of course that's a limitation, but to do what kind of if you do testings, there's not really a point from a clinic. There's no use from a clinical point of view to test at all these different occasions because a lot of the women will already have delivered by then.
I see.
So, but there is variation throughout the day, and I think also I think that the time of the season, the time of the year, has some importance as well.
Right. Because my follow-up question there is, could it be so that among these 4 major biomarkers you have discovered, perhaps they have to be prioritized depending on when the emergency is happening? Perhaps or do you need to show them all 4, or is it 2 that might be important in the morning and the 2 others in the afternoon or something like that?
Oh, that's it's an interesting thought. Well, that would have to be investigated.
Yeah,
I don't know.
No, one cannot know everything. I just got curious from reading and listening to the discussion with the opponent here. And then my final question would be then that you have this oxylipid that was kind of protective as far as I could understand. If you have an individual then with, let's say, 3 of these predictive markers for preterm labor and then high amounts of this protective oxylipid, would that be a way to interpret that, perhaps this one will prevent it from happening? Or can you make this kind of grading or scale of that now the risk is reduced or now not, or do they balance each other in some way?
It's too early to say, I think, but it's really an interesting thought, and I don't think we can draw this conclusion from our data, but it's now I lost it again. I lost the question. What was it? Sorry.
No, I just wonder if you have a few parameters or a few of these, let's say, protective biomarkers, and you have them mixed in with your risk parameters. Do they balance each other out? So suddenly the risk risk parameters are not that risky any longer. Would you expect
I think that's a new study, actually. Because I don't think it's as easy as if we just statistically adjust in the statistical models for other risk factors. I think that would need a study of itself, of its own, to be answered, really.
Yeah, because that was the thought. Is it possible to construct a model where you test your kind of conclusions in a test system where you prove that they are the ones that drive the preterm labor or not? And what kind of test system would that be?
Wow. I mean, you're asking about the mechanisms, not just to show what's a biomarker, right?
Yeah, that's true. Sorry about that.
No. I mean, it's difficult in obstetrics, but there are animal models, and there are mouse models for preterm birth, but personally, I'm a little bit skeptical. But the presentation is a little bit different, and of course the time that you're pregnant is very different. But from what I've understood, it is a little bit comparable, the trimesters also in mice. So I suppose you could use perhaps some kind of knockout mice, or construct some other type of model to if you want to study specific oxylipins. But then if you want to have the clinical risk factors included in the model, then it becomes, animal model is not a good idea at all.
No, I was thinking of pigs. I got introduced to pigs last week, so I got encouraged. They are relatively similar to us humans in many ways. I learned to know. But very good. Yeah. Thank you for being patient with my questions, and good luck with your work. Thank you very much.
Thank you so much.
Thank you, Jorma. Now I'm the last in the committee. This is also out of my scope, but in a way not. Because even in cardiology, we have a lot of these omics to discuss and to test and so on, and together with clinical risk markers. You have been looking at the proteomics, and you were saying that you will do the genomics. At least you are interested in it, or?
Well, yes, but I think the study population that we have is perhaps not suitable for genomics. But what we could do is that we could investigate previous findings, see if we can verify them, because we have a very well-defined cohort of women with previous preterm birth.
What about metabolomics then?
Yeah, there are these multi-omics. There is one paper with multi-omics published on preterm birth, pregnancy really, where it's shown that a lot of omics vary in a predictable way during pregnancy. So perhaps that's a way to go to try and understand the mechanisms behind preterm birth. But they're not probably just in one omics area, but in several.
And could it be practical, clinically, to use that in the future?
Well, perhaps to identify women in early pregnancy who are at later risk for preterm birth, but I think it's a lot more difficult in the situation with preterm labor, which is an emergency situation, and so that's a lot more difficult, I think. But if you can find women who kind of deviate from the plan already in early pregnancy, then and if they have deviations in different omics areas, maybe that could also be a way to discover or at least to study different types of preventive strategies for these women. So I think that's really interesting.
I would you have been doing a scientific education during these years. It's usually some years.
Yes.
And I was just looking. I was stuck on paper 2, as these reviewers that you have sent it to, I suppose, too. How many did you send it to?
We've submitted it 5 times.
Yeah, because I have had some very big difficulties in the results part. So difficult to read it through, and it was a mix. At least I think I'm a bit critical here now.
Yeah, that's
background and the statistics and results and everything. So I think you said that maybe you will divide it in 2.
Yeah,
maybe that is a very good idea.
Yeah.
Because it was very difficult to read these results parts.
Yes, I understand.
And then I was really wondering, because you have the same results in 2 and 3. You have the same figure, you have the same wordings in the results in number 3. I suppose 3 was first and number 2 was afterwards, or as number 3 is published already.
Yes, number 3 is published.
Yeah, I mean, this C figure in number 3 is it the same as in figure 1 in number 2?
No, they're a little bit different, I think, the figure.
I couldn't see the differences then. But anyway.
Did I put the wrong figure in, perhaps?
Could be. There are so many
I've only read this about 100 times.
But anyway, I understood it so that in...
the panel C part. Yes.
But panel C, if you use it once more, then you could use it in the methods if you have published it already. That is what I was thinking. Otherwise, you can't have the same results in two articles. It's not possible. But then I was wondering, as I am a cardiologist, and you are handling, as you are an obstetrician, I understand, both a mother and a child.
The mother and the fetus.
Yeah.
Once it becomes a child, it's somebody else's patient. That's very important.
But you have a good communication with the pediatricians to take care of the fetus afterwards. Have you ever been thinking about what will happen with the mother and the child in the future regarding cardiovascular diseases? Because we all know now, even if it's not so much observed, that preeclampsia is a risk factor for developing cardiovascular disease around 20 years later. And we know that low for gestational age in the fetus is also a risk for cardiovascular disease in the child when it grows up. Have you thought about why is it like this? Does it have anything to do with preterm birth and so on? And especially when you have given overweight as one risk factor for preterm birth and these things. Can you just elaborate upon that?
Wow.
Because that is because in between the partners when they deliver and when we get them as cardiologists, it's a huge gap, and we have to narrow that gap to be able to prevent these women and these children from getting myocardial infarction and so on.
Yes.
Can you just hypothesize, elaborate a little what you think? You have done this analysis.
A lot of children to mothers with preeclampsia are also born preterm,
interesting.
Yes, because I mean, not due to spontaneous preterm labor, but because they are induced, because we have to cure the mother from her preeclampsia. So it's an indicated preterm birth, medically indicated preterm birth. And I don't know when preterm birth is considered a risk factor for later cardiovascular disease. I don't know if there has been adjustments for the reason of preterm birth. So I don't know if women or if children from preeclamptic mothers have a bigger risk of cardiovascular disease later in life than than children who were just spontaneously born preterm to mothers who are otherwise healthy. I don't know that.
There's nothing published about that?
Not to my knowledge. I don't know.
Be something for you to do.
Sure. But now I'm not specialized in preeclampsia, but of course it's something that I work with very often, and it's a very, very interesting disease, and we're still trying to understand that one too. And they have also inflammatory changes, but what really drives the cardiovascular disease in the children to the preeclamptic mothers must be something that has to be well, probably it affects the endothelium in very, very early in fetal life as well. And I mean, if you have a little start there, and then other risk factors contribute, because obesity is also a risk factor for preeclampsia.
What is it in the adipositas that is the risk factor then? What is the mechanism? I mean, you were on this number 3.
The mechanism of a risk factor?
Of the fat. I mean, and then we have different fats in the body also.
Yes, and I'm sorry, I know very, very little about this, but obese persons are also more prone to inflammation. So I think inflammation is the problem. Yeah.
It seems to me that it is linked together in some way or the other, and we see it from one perspective there and one perspective there, and somebody should see the whole thing of it. But maybe we can do it together, and at least nowadays cardiologists and obstetricians and gynecologists work together more than we did before. So maybe in the future for the women and for the men if they are early for gestational age. Otherwise, I don't have any more questions. I would like to continue this dialogue, but I must say that I really appreciated this kappa, the first thing, and read it with and learned a lot. You made this very well. It's like a lecture book.
Thank you.
So now I am ready, and now we are leaving the questions for the auditorium. If you have any, have you them?
Yes, thank you, all people involved. No, we haven't got any questions on the chat. So,
good luck and well wishes.
Yeah, many well wishes. Yeah.
Then I can end this session then.
Yeah, you can. Yeah.
Thanks everybody. And for a very nice opposition, a very nice defense, and it was a very nice and happy dissertation. Thank you very much, all of you. And now I leave you over to our host again.
Yeah, Thank you. So now there will be a Zoom room opening, actually the same Zoom room that we have been in for some time now. So people that are watching at YouTube can join. So it will soon appear. And then we will have a digital meeting, the committee, Teresa, the opponent, and the supervisors. So it will take some time because we will go into another physical room. And so I think in 10 minutes or so. And you have another link for this meeting, Teresa, Bo, and Jorma, and Maria also. So if you have any problem, you can email or call. But otherwise, the few of us will meet soon.
Okay.
Okay. Thank you.
Ska vi ta en dator eller ska vi ta flera? Jag tänker om
I'm sorry, it's mute. We cannot hear.
We don't hear. We don't hear anything.
Can you hear me now?
Yes.
Okay. Dear Maria, we have now sat down and discussed you and your development during your PhD studies and your performance today. And we cannot say anything else than that you performed it very nicely, and we approve very much that you are now a PhD, the highest examination that you can have in the university. Congratulations.
Thank you very much. Thank you so much.
There will be a skål later, but while we're waiting for that, we can have a fyrfaldigt leve. Hon lever, hip hip, hurra, 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 hurra.
I would just like to thank you, Teresa, for a very nice discussion today. I was really nervous beforehand, but you were very nice and asked very interesting and relevant questions that were not too tricky, I think. And I've had a lot of ideas for the future, I think. And I also want to thank everybody on the committee, of course, for your interest. You all have, I'm quite amazed that somebody has actually read what I've written. So thank you so much for all your effort. Thank you.
Där satt den.
Perhaps we're closing the Zoom now, or do you want to stay? Okay, the YouTube link will be closed.
Jag får säga bara jättestort grattis Maria, du var jätteduktig.
Tack Maria.
Grattis Maria, vi hoppas på mycket. We hope for very much good research. You have a unique opportunities and you have a broad knowledge now. So we really have great hope for the future as well. But first, celebrate this. You have done a fantastic work and you have a very broad experience.
Thank you very much. Thank you. I'm looking forward to collaboration in the future, maybe.
Yeah, you're welcome.